From the Heart.org Medscape Cardiology, this is the Bob Harrington Show. Dr. Robert Harrington is the Arthur L. Bloomfield Professor and Chair of Medicine at Stanford University.
Hi, this is Bob Harrington from Stanford University here on Medscape Cardiology and the Heart.org. I hope you listened to our end of the year wrap up with Mike Gibson, where we covered some of the important clinical research findings that had emerged over the past year. On this one, we're going to go in a little different direction. I've asked Mike to stick around for a brief conversation about some of the trials and some of the learnings we had more on the public health front. And as part of that, we're going to talk about COVID and some of the issues that we continue to learn in over the course of the pandemic. Largely, we're going to focus on the cardiovascular aspects, but we may move into some other areas. So again, thanks for joining us. My colleague, my good friend from Boston, Dr. Mike Gibson, professor of medicine at Harvard Medical School, interventional cardiologist at the Beth Israel Deaconess, and director of the BAME Institute, an academic research organization. Mike, thanks for sticking around for part two.
Thanks, Bob. Thanks for having me again.
Well, let's get into the public health. Certainly as trialists, I've applauded some of the design features of these massive public health studies that have tried to get at questions which, some have said, boy, that's a tough one to tackle. And let's talk first about salt substitute. I mean, cluster randomization, using rural villages in China, trying to understand if a salt substitute might produce better cardiovascular outcomes. It's getting at that question of, too much salt, particularly sodium, is bad for us as a population. And boy, what a neat design, challenging thing to pull off, but these investigators pulled it off.
I think, Bob, COVID and everything highlights the need for keep it simple. I think we need patient-rich, a little bit, I don't want to say data poor, but less of an emphasis on lots of data per patient, but we need lots of patients to answer these important questions. You and I sweated through these randomized trials, hoping we have enough events, hoping we have enough power to answer the primary endpoint. Not an issue here in these trials. The question gets definitively answered. These are important public health issues that have a lot of debate surrounding them. And it's great to see the question answered definitively.
Yeah, and it really, putting my AHA hat on and the work that we've gotten involved with over the last few years regarding advocacy, having a foundation of high quality evidence to push the policy discussions is so important. The salt one being a great example, right? It is a policy issue because it plays into things like, how do you regulate food and what goes into food and what kind of recommendations do you give school kids for what kind of, what's the food that's being served at lunch, et cetera. It really, Mike, to your point, we've done these trials to look at therapeutics, but public health is actually a bigger field where we can have a bigger impact.
I agree, Bob. And, when we do trials, it's often a select group of patients. The thing I love about these trials is they're broader, much more real world, much more generalizable results. Now, I will say, different populations genetically may have different salt handling. So, the same kind of question should probably be asked in, different groups of patients, in the United States and elsewhere with different, genetic makeups. This is an important answer to the question in this one population, but it'd be good to see the answer in other populations.
Yeah, good caveat, Mike. One of the issues with salt is the blood pressure issue. And during the pandemic, as you know, we've seen a loss in our country with blood pressure control. We've actually lost a fair bit of blood pressure control as a population. So we're clearly
particularly, Bob, during COVID.
That's what I mean. Yeah, particularly during COVID. Yeah. Particularly during COVID. And because of that, Mike, we're going to need some new strategies. And there were two strategies with recent trials that I really enjoyed hearing about. One done, again, outside the United States in rural villages, where the so-called village doctor, you think of this as community health workers, were really instrumental in a randomized trial of controlling blood pressure better than usual care. Boy, that has some relevance to our country with community health workers and a workforce not dependent upon physicians.
Yeah, Bob. And the other thing I want to emphasize again is the generalizability of these kinds of results. You're not talking about some fancy academic medical center in a wealthy zip code. We're talking about real world outcomes from a simple real world intervention that sometimes is not applied in 100% of people with 100% compliance. But this is the answer to a strategy, a public health strategy that can be applied broadly.
Well, Mike, your own healthcare system, I thought, took that sort of concept of a non-physician workforce and or a workforce other than physicians is maybe a more appropriate way to say that, and used the digital world in part, but used messaging and used devices at home to manage blood pressure. Kudos to your colleagues at Mass General Brigham. I think it was like 10,000 subjects that they were able to demonstrate better blood pressure control. You want to comment on that one?
Yeah, that's the concept of healthcare navigators. I got to be honest, some physicians were uneasy with this. You're taking away my patient. This is my patient. I want to manage them. And I can understand that, but it's hard to argue with the results that more of a guidelines-based algorithmic approach with a lot of touch by someone who may not be a physician yielded really, really good outcomes. And the same thing Bob has seen on the statin and LDL side of things. It's not something that may require the level of care of a physician. These are kinds of things, compliance and adherence and targets are maybe something that other healthcare providers can help with.
Yeah, our colleagues at Kaiser showed this a number of years ago that a pharmacy-directed program with nursing clinical support can really provide good blood pressure control across, in that case, a captive audience based on their payer situation. But for a system that's a little more heterogeneous, like Mass General Brigham, which would be more akin to our heterogeneous payer population here at Stanford, I was really impressed that bringing these teams of people together at scale is really doable. That's part of the issue too, isn't it, Mike? I mean, this one, I think, if I remember, had 10,000 patients involved.
Yeah, I mean, scale has taken on a whole new meaning in the virtual and digital world. We're trying to do the Heartline trial of up to 150,000 patients. When you go digital and virtual with apps, these things are very scalable, particularly if you have a lot of algorithms that are there, guideline-based algorithms that require less human intervention. But human touch is still very important. Getting in touch with these patients, really showing them, that you care about them. No one cares how much you know unless they know how much you care. And I don't want to cut out the health care and replace it with an algorithm. But I think we can see that the two together work quite well.
My friend Abraham Verghese, the well-known author, who's our vice chair of education here, and Nigam Shah, who's one of our informaticians. We wrote an editorial, a viewpoint in JAMA a few years ago, where we said, what this computer needs? This computer needs a physician.
Yes.
Making the point that it's this intersection of human intelligence and artificial intelligence that really, healthcare at the end of the day is a personal relationship. And yes. You want it based on the best available data, but you also want it in the context of that individual patient's values, their preferences, understanding their social context. So I could not agree with you more. Mike, let's make the pivot to COVID. And last year, you and I talked a lot about COVID. We were coming sort of to the end of the first 9 or 10 months of dealing with the pandemic. Now we've been through another year. Let's focus from the clinical trials perspective. I don't want to get into the myocarditis, the vaccine stuff. We can do that another time. I think Manesh Patel and I have had good conversations about that. But let's focus on the trials, infrastructure, and apparatus. Our friends in the UK, led by Martin Landry at Oxford, boy, did they do a public service for the globe.
Yeah, they did. And look, we know what the questions are. we have so much experience in designing good case report forms. The case report forms don't need to be rebuilt all the time. We need to do what they've done and other countries like Sweden have done.
Yeah.
We need to build an infrastructure, a backbone to not only help with this pandemic, but to get ready for the next one. So that when something like this happens, we can very, very quickly, in large numbers of patients, answer public health questions definitively, safely, and quickly. We can do it. It's not a matter of can we do it. It's a matter of do we have the political will to stop acting like individual clinical researchers and come together as a community.
Well said, Mike. You and I were both involved in the CVCT meeting this weekend. We're dealing with clinical trials, and I was involved with one of the sessions on COVID. And I made the comment that, and I'm very involved with the NHLBI clinical trials for COVID in the COVID space. But I made the comment that in the US, we have this individual approach to clinical trials. And that's why we see so many small trials that, are hopeless in terms of being able to yield a real answer, because it's the individual. And I get that. We're rewarded as individuals. You got promoted, I got promoted because of our individual accomplishments. But really what we need if we're going to affect the public health is a more group ethos, which certainly our friends at Oxford have tapped into.
Yeah, this isn't a scientific question. This is more of a geopolitical question. And it's really something all of us have to look into our souls and say, am I willing to give up some of my own personal autonomy, credit, and control to participate in something that's bigger than myself to help the world? And I hope the answer will be yes.
Mike, we hadn't prepped for this one, so I'll put you on the spot a little bit. If you were to give the NHLBI or maybe the NIH more broadly one piece of advice about their clinical trials, what would it be?
Build a reusable backbone. Yeah. Stop reduplicating, building the car over and over again every time you're doing it. Just build a backbone we can all use. We can all do our own trials off that backbone. If everyone wants their little individual trial, we've got a backbone, same endpoint, same definition, same everything. But we just need a good backbone. The
so-called platform to be able to do these things. I think that's well said, and and it goes beyond the networks, which are really very narrowly focused on certain diseases, et cetera. What you're really talking about is a national clinical research infrastructure.
We need a national research. Look, in the world of atomic, subatomic particle physics, they come together at CERN.
Yeah.
Everyone gets credit. Everyone's going to get famous as being part of it. Join the group.
Yeah, a physicist once told me that you can be for your entire career like the best at a piece of what those experiments need, and you're always fifth, sixth, seventh author. You're never the lead or the senior, but in their community, they know what that means.
Right, and that's what's important is your own community.
And so that's a good piece of advice for a national infrastructure to be able to do the kind of trials that need to get done in a timely way. When I hear Martin Landry talk about, 2 weeks into it, they were already beginning to think about randomizing patients. That's extraordinary. It took the US a lot longer. I mean, I think we've done some good things, but nowhere near that sort of national focus on contributing to the public good. So that's a good message.
And you don't have to be a wealthy nation like the UK or the US. There was a cluster randomized trial of hundreds of thousands of patients looking at masks versus no masks. Again,
in Bangladesh.
In Bangladesh.
Yeah.
All right. Bangladesh can do it. Why can't we do it? I think we know why. We're our own worst enemies.
Yeah, and at the same meeting, I mean, Renato Lopez from Duke, who's Brazilian and who runs the Brazil Clinical Research Institute, he talked about how that country came together to do some of the trials. And again, kudos to them. They answered, for example, I thought one of the most clever trials of the pandemic. They did the ACE inhibitor withdrawal trial to try to get at that question of the ACE inhibitors dangerous in patients with heart disease in a COVID era. So very clever.
And they did it quickly.
They did it very quickly.
And it showed that, all this ACE withdrawal and all the worries about all that really didn't have much of an impact. So.
Yeah, no, many of us were pouring through the observational data sets that we had available, and they actually went and said, no, let's do a randomized trial to get at the definitive answer. So,
Bob, that is one thing we should learn from this, that observational data is no substitute for randomized trial data.
Yeah, Greg Fonarow has that classic piece now in JAMA Cardiology, randomization, there is no substitute.
Do not substitute. Yeah.
Use observational data for what it's good for, which is generating hypotheses and learning about things like practice of care, patterns of care, et cetera. But when you want to have causal inference, you need to randomize.
Well, I lined up, you may have seen on Twitter yesterday, I lined up the wastewater in Massachusetts.
I saw that, yeah.
Lined up perfectly with cases, lined up perfectly with hospitalization. But you wouldn't want to conclude that wastewater is causing the pandemic. Yeah. You just got to get causal inference right.
Yeah. Well said, Mike. Well, Mike, there's been a terrific discussion as we wrap up our 2021 overview. There's been a lot we've learned this past year. The first segment was really the clinical trials. The second segment is dealing with some of the public health issues, including our response to COVID. As always, Mike, my good friend from Boston, Harvard Medical School, Beth Israel Deaconess, and the Baim Institute. Thanks, Mike, for joining us here on Medscape Cardiology.
Bob, it's always one of the highlights of my year to do this with you. Thanks for having me.
Thanks for being here.